Hello, everyone. My name is Lynn Webster. I'm the Executive Vice President of Scientific Affairs at Dr. Vince Clinical Research and was the principal investigator for the study that I'm going to discuss today. On behalf of my co-author, I will be presenting a review of the primary and secondary outcomes from a phase 1 study comparing the respiratory effects of buprenorphine buccal film and oral oxycodone hydrochloride administration. My disclosures are that I serve and have served as a consultant for Cognificence, Collegium, Elysium, Insice, Quivia, Salix, and Trevi. I've been on the advisory board of AdhereRx, Insice, ChemPharm, and MedLogic Communication. I've also received travel expenses from AdhereRx, Elysium, Insice Biosciences, and PainScript. Overdose due to respiratory depression, whether from abuse or medical use, is a major concern with opioids. Buprenorphine is an atypical opioid acting as a partial agonist at the mu-opioid receptor. Unlike full mu-opioid receptor agonists, such as oxycodone, studies by DeHaan and his colleagues have demonstrated that buprenorphine has a ceiling effect on respiratory depression, indicating that beyond a certain dose, the risk of respiratory depression does not increase. Buprenorphine buccal film, or BBF, is approved by the U.S. Food and Drug Administration for the management of severe and persistent pain that requires an extended treatment period with a daily opioid analgesic and for which alternative treatment options are inadequate. We previously conducted a randomized, double-blind, placebo-controlled double-dummy crossover phase 1 study to compare the effects of BBF and oxycodone immediate release administration on respiratory drive, pharmacokinetics, oxygen saturation, and pupillary constricting effects. This is a review of the previously published data from that study. The study included healthy men and women who self-identified as recreational opioid users but were not currently dependent on opioids, as confirmed by a naloxone challenge test. Participants were administered 300, 600, and 900 microgram BBF, 30 and 60 milligrams oxycodone immediate release, and placebo. As shown in Figure 1, every participant was randomized to receive each treatment and placebo once, with a 7-day washout period between treatments, allowing subjects to act as their own controls. Each treatment was combined with an oral or buccal placebo as appropriate for the double dummy design. The study protocol was approved by an institutional review board. Respiratory drive was evaluated by measuring the subject's ventilatory response to hypercapnia by assessing the maximum decrease in minute ventilation, or Emax, before and after administration of each treatment. Pupil diameter was measured by standard pupillometry. The ventilatory response to hypercapnia assessment and pupillometry were performed pre-dose and at 0.5, 1, 2, 3, and 4 hours post-dose. At each time point, subjects were allowed to acclimate to room air to establish a regular breathing pattern and then received a hypercapnic gas mixture consisting of 72% nitrogen 21% oxygen, and 7% carbon dioxide for 5 minutes. The procedure was terminated if the subject reached an end-tidal CO2 of 60 millimeters of mercury for 3 consecutive breaths. During the treatment phase, blood samples were collected pre-dose and at 0.5, 1, 2, 3, 4, and 6 hours post-dose for pharmacokinetic analysis. Pharmacokinetic parameters were evaluated using non-compartmental methods. As shown in Table 1, 19 subjects enrolled, 16 of them partially completed the study. That means they completed at least 2 study treatments. And 15 completed the study. The subjects were predominantly white and Caucasian, men, approximately 33 years old, with a mean body mass index of 25.4 kilograms per square meter. Figure 2 depicts the study's primary outcome, showing each treatment's effect on respiratory drive. The minute ventilation at Emax did not decrease significantly with BBF relative to placebo. In contrast, oxycodone 60 milligrams reduced or resulted in a significant decrease in minute ventilation at Emax compared to placebo. The maximum observed plasma concentrations of both opioids increased proportionately with increasing dose. However, buprenorphine had a slower Tmax than immediate release oxycodone, as outlined in Table 2. Looking at Figure 3, the mean decrease in oxygen saturation was greater for oxycodone compared with BBF. Figure 4 shows the differences in pupillometry for each drug compared to placebo. Significant meiosis began approximately 2 hours after BBF administration compared with immediate release oxycodone, which showed significant least squares mean decreases at 30 minutes post-dose. These study results suggest that BBF may exhibit an improved respiratory safety profile relative to immediate release oxycodone. However, additional studies are needed to confirm these results. Thank you for your interest in this study.